Hello, sir. I'm Dr. Ismail.
How are you doing?
Heart, is that okay?
Yes, of course.
Okay. So start by looking at your hands. Pop your hands for me, please. Turn them around for me. Okay, that's fine. Checking your pulse. I'm going to check your groin, please, as well. Is that okay? That's
Yeah.
fine. Any pain in your shoulder, sir?
No.
Okay. I'm just going to lift your arm up. Yeah. Okay. Rest your neck for me, please. Have a look here now. Okay. Open your eyes for me, please. And look down for me. Okay. Open your mouth for me, please. Pop your tongue out. Okay, that's fine. Thank you. I'm going to press your neck, just tendons. Okay. That's okay, thank you. I'm going to check here. And have a listen to your heart. Can you turn slightly to the left for me, please? Okay, turn straight for me. Listen to your neck. Stop breathing for me, please.
Stop.
Yeah. And breathe normally. Can you lean forward for me, please?
Sure.
And have a check your pulse. Big breath for me, please. And out. And stop breathing, please. And breathe normally. Okay. And press on your back. Breathe in for me, please. And again. Okay. You can lie back now. Thank you. Do you have any pain in your legs at all?
Well, I've had a knee joint replacement, but I don't have pain at the moment.
Okay, thank you. I'm going to press in your shins there. Okay. Thank you very much, sir. On general inspection of this patient, he was comfortable at rest and he has gynecomastia. On checking the pulse, the patient had an irregular pulse which was 66 beats per minute. There was no collapsing pulse. The central venous pressure was not elevated. There was no cyanosis. There was mild leg edema, mainly in the right leg. On palpation of the chest, the apex beat was not displaced. It was in the fifth intercostal space and there was no any palpable thrill. On auscultation, the patient had a normal first and second heart sound, and there was a pansystolic murmur, mainly louder on the apex area, radiating to the axilla. This patient has got a diagnosis of mitral regurgitation and he was not in heart failure. That was evident by the patient was in atrial fibrillation with a pulse rate of 66 per minute, and there was, on auscultation, there was a pansystolic murmur which was radiating to the axilla. The patient was not in heart failure, as there was no basal crepitations and there was no sacral edema, although there was a mild leg edema on the right side, but that was mainly possibly due to venous insufficiency. I would like to finish my examination by checking this patient's blood pressure and also checking the urine dipstick for evidence of microscopic hematuria. The examiners expect the candidate to know the common causes of mitral regurgitations, which are mainly degenerative mitral valve disease, rheumatic heart disease, left ventricular dilatations, and mitral valve prolapse and papillary muscle dysfunction. They also expect you to know the acute causes of mitral regurgitation, especially post-myocardial infarction and infective endocarditis. The examiners also expect you to know how to investigate these patients by, for example, checking the ECG for signs of arrhythmia, like in this patient, for checking whether this patient has got atrial fibrillation, and also echocardiography to know the severity of the mitral regurgitations and also other valvular heart disease. The other important factor is the examiners will expect you to know the signs of severity of mitral regurgitations, which are mainly when the patient is in heart failure, or the patient has got a soft first heart sound, if the patient has got third heart sound, also if the patient has got evidence of heart failure. The other signs to look for in the patients with mitral regurgitations, it looks for other valvular disease, especially mitral stenosis, and also if there is a patient has got third or fourth heart sound, and also splitting of the second heart sound due to the severity.